Good afternoon, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Thank you if you've joined us. It's not our usual time. Normally we're on Tuesdays at 11, but I was actually away on vacation and then at a conference. But we continue to get questions in, so did want to give you a chance, as always, to have your COVID questions or other public health questions addressed. We will be returning to our regular Tuesday schedule next week, so I'll be on Tuesday at 11 this coming Tuesday. But there's a lot to cover today, and so I think let's go ahead and we'll get into it. You can go ahead and put your questions now in the box below, or use the hashtag AskDrArwady on either Facebook or Twitter. As always, we'll start with the dashboard. chi.gov/COVID- is where we see our COVID dashboard. And if you pull it up, first you see right up at the top that Chicago's COVID-19 risk level is now medium. Last week, we saw enough improvement that we moved from high down to medium, which was good news. That was predominantly based on decline in COVID cases being hospitalized actually outside Chicago. But regardless, the region is doing better and our case counts are also coming down a bit. That said, there's still a lot of COVID around, and I encourage folks to continue wearing masks in indoor settings. If we look at the numbers overall, you'll see we're averaging about 675 confirmed cases a day. And just to remind you, these are cases of people who actually get a formal sort of PCR or reported test done. It does not include a lot of home tests. So it's down 22% from a week ago, but we've seen a big change in testing patterns, and we'll talk about that. We're just seeing about 15 Chicagoans being hospitalized every day, also coming down nicely. That, of course, is not dependent on testing. If people are being hospitalized, they're being hospitalized, but there's a lot of testing that occurs in the hospital setting. Deaths also remain really low. Vaccinations, we're doing about 1,800 a day right now. Now, if you look here, you'll see tests have dropped by about 50, almost half, 57% from a week ago. And positivity has jumped up. It's about almost doubled from 5.8% to 10.6%. This is all about changes in testing with Chicago Public Schools going on to summer break. So for those of you who've been following closely, we had a notice up on the top of our dashboard for a week or two in advance warning folks that this would be coming. And I certainly got a few slightly panicky calls and emails and messages from people really worried about this 10.6% positivity. But remember, positivity is positive tests divided by all testing that is done formally. And so if your testing drops in half, you would actually expect your positivity to double without any actual change in how COVID is showing up in our community. And so it's part of why we actually don't use positivity in calculating the community COVID levels. Cases obviously also would be affected somewhat by that, but remember, most of the testing in Chicago Public Schools is asymptomatic. It's screening testing. And so what we know is that one of the reasons positivity is higher is that so many people are getting home tests. We like home tests. I want you to use home tests. I use home tests. I took one yesterday. I took one the day before. They're very, very good. But most of those don't end up being reported. Typically, if people are symptomatic or they've had a positive home test, that's when they're coming in to get a test in the clinical setting, sometimes to confirm. You don't need to do that, but we see people doing that. And so people are also more likely to test positive in those settings. So all to say, things are continuing to improve. And I am feeling pleased about where we are. I also just wanted to remind you, down at the bottom here, based on feedback that we've gotten largely through Facebook, we've put direct links to some of our other COVID-19 data. This is the same as there's a latest data tab up here, but it just makes it a little bit more visible. So if you're wanting to see exactly what's happening with Chicago hospital capacity, or community risk and transmission, wastewater surveillance, variants, vaccine coverage, including boosters, vaccine effectiveness, some of the social impact survey stuff that we've done, our data portal, which is where you can download the data if you want to do your own analysis, the Health Atlas, which is where we put all of our health data. You can look up by neighborhood, all kinds of things, and then older archive data reports. So let's pull up some slides. I have some kind of in the news things up first. So first of all, I did just want to wish folks, I wanted to wish people happy Pride Month. I seem to have some captions coming here. I'm not sure. Okay. And also, obviously, this week was the week that we celebrated Juneteenth. If folks have not seen that picture on the left there is actually the formal Juneteenth flag across the U.S. It's in Chicago colors, but it's the flag for the whole U.S. These are some of the CDPH staff members celebrating Juneteenth here on the right. And I hope all of you had a good opportunity to talk about Juneteenth and what it means. I also wanted to highlight an announcement that we made while I was out last week, that the CDPH with Mayor Lightfoot, we have further expanded the Citywide mental health network. So just as a reminder, we call this the Trauma Informed Centers of Care Network. And the idea is the city operates some of its own mental health clinics, but also we've been wanting to increase access to everybody without barriers across the city. And so we've been partnering with, you can see all of these providers here on the right. The city is providing funding. And then these organizations are providing mental health services to all Chicagoans, regardless of insurance, immigration status, or ability to pay. And it's let us build up a network. So if there are people who are needing to get connected, we have many places all across the city that we can connect them for outpatient care. Please go to mentalhealth.chicago.gov if you want to learn more. And obviously, there's lots there about getting connected to care yourselves if you need it. Unspoken is the campaign that we're doing right now around trying to make mental health something we talk about more, not leave it unspoken. I also, if you're interested, tonight, CDPH is hosting, along with the Healthcare Council of Chicago and Fellowship Chicago, a screening of a documentary called Tipping the Scale. It's won a number of awards. You can see the tagline there, Addiction Isn't a Choice, Compassion Is. And it's happening this evening at Fellowship Church Chicago on the south side, 4543 South Princeton. The doors are opening at 5:30. Screenings at 6:30. It's free. There will be some discussion. So I encourage anybody who's interested in the opioid outbreak to come on down. And then lots of questions about monkeypox. So I will just hit very high level. As a reminder, monkeypox is rare. It's spread through close contact, and common symptoms, rash or unusual sores, and the basic message is to avoid close contact. On the left here, you see some examples of what this rash can look like. Sort of bumps is often what we'll see. This is a rare viral infection, so it is a virus. It is not related to the COVID virus. And typically people will get a flu-like illness and then this rash that can look like pimples or blisters or bumps. But some people only have a rash, and spread can occur from person to person if there is skin-to-skin contact with one of these rashes or sores or body fluids. And so typically we can see exchange if there's respiratory secretions, if there's prolonged face-to-face or intimate contact like kissing or cuddling or sex, or touching items like clothing or linens that previously had touched the rash. And anybody can be infected with monkeypox. As of now, we've seen 23 Chicagoans be diagnosed with monkeypox. Overall risk remains low, but we do want you to see a healthcare provider if you develop symptoms. Most, but not all of our cases here, similar to across the country, have been in gay, bisexual, or men who have sex with men. And it's not clear always how people were initially exposed, but we do see spread occur through these tight-knit social networks. So if you have a new or unexplained rash, just like you would hopefully do outside of monkeypox concerns, but regardless, please visit a healthcare provider. And then if you don't have one, you can give us a call, 312-746-4835, and we can help get you connected to care. Remind your provider that monkeypox is in the community. We've been doing a lot of education to providers, but they'll want to be able to potentially just take a swab of the rash to get a test if they have concern that it could be monkeypox. And then avoid sex or being intimate with anyone until you've been checked out. So that's the update there. Where we look at COVID across the world, We are up to 540 million diagnosed cases and over 6 million deaths, of course over 1 million just here in the U.S. We're at almost 12 billion vaccine doses being administered, and more than 2/3 of the population, the world's population, 68%, is now vaccinated, which is pretty remarkable. You'll see there's still a lot of COVID in Europe, in Australia, etc., but all over the world we're seeing a lot of cases, and especially if there's been good vaccine uptake, not a lot of very serious hospitalizations, deaths, etc. So that's been good. In the U.S. here, nationally, we're averaging 29 diagnosed cases per 100,000 people per day. Chicago's a little under that now at 25. Illinois is a little over that at 32, but generally seem to be getting through that recent surge. Here's what's happening with variants. Everything is still Omicron here in Chicago, in the Midwest, across the U.S., but we've continued to see this really quick evolution of more infectious, more contagious Omicron subvariants. So whereas earlier it was, BA2. Now in green there, we're seeing BA4 and BA5. BA4 is about 14%, BA2 is about 9-10% in the most recent week. And BA4 and I'm sorry, I misspoke. BA4 is 14%, BA5 is 24%. And BA4 and BA5, as you can see, I think we've talked about how to read this graph, but let me just remind you, every line vertically is a week. And so the line on the left here is from March, the week ending March 19, 22, and then the one on the right ends just June 18 last week, 22. And it's showing each week what percentage of all of the tests that are done are which variant. Everything's Omicron, but in this most recent week, the light pink up here, the BA2, that's the one that's now about 9%. This BA2.12.1 is about 53%. BA4 is at 14%. And then at the bottom, BA5 is at about 24%. And BA4 and BA5, as you can see, just like the ones before it, are growing quickly. And we are starting to see people who had earlier versions of Omicron get reinfected with BA4 and BA5. It seems to be less protective. Prior infection does, especially for BA4 and BA5. But luckily, vaccine continues to be effective, especially against severe illness. And if we look across the U.S., you see those same colors, those green, the BA4, BA5 really sweeping through fairly quickly. We actually have more of it here in the Midwest than some other areas are reporting. So overall, keeping an eye on it, but reasonably confident about where things are. Just continue to be careful, and please get up to date with vaccines, including boosters. 40% of U.S. counties are now reporting a high or a medium COVID level. That's partly because of the rise of BA4 or 5. As I said, Cook County did move from high to medium level as of last Thursday. And you can see that we've got sort of a mix of yellow, orange, and green counties right now across Illinois. Masks are still strongly recommended indoors while we're at medium. I'm hopeful that if we continue to see progress, we may get back down to the low level. A lot of that's going to depend on what happens with the variants, at which point we would remove that recommendation. But we do still strongly recommend indoors. And just to put a few numbers on this, the new cases per 100,000 population, the goal is to get back down under 200. You'll see both Cook County and the city are at about 222, 221. Our new admissions, we want those under 10, and they are, and hopefully continuing to downtrend. And then this percentage of staffed inpatient beds occupied by COVID-19 patients, we want that to stay under 10%, and you can see it's well under 5%. So continued progress. We are seeing a lot of first-time and mild COVID infections right now, averaging 675 a day. We already talked a little bit about test positivity, but just as a reminder, the reason test positivity is up is because tests performed is down. And there's nothing that is particularly concerning to me. We expected to see that change in positivity. If we look at the hospitalizations a little closer, just in some context, our all-time peak was January 4 of this year. We had 301 Chicagoans admitted with COVID in a single day across the city. And we had more hospitalizations from COVID during the Omicron surge than in any prior time. But that's come down really well. We're averaging about 15 Chicagoans across the whole system being hospitalized each day. And as compared to more than 50 Chicagoans with COVID dying every day, like we saw at the very beginning of COVID, we're seeing fewer than 3 Chicagoans dying from COVID per week right now. And you can see that's been good since we came out of that big surge in January. I get a lot of questions about boosters, and I wanted to just highlight that the reason that we strongly emphasize getting the booster dose now is that they work. They provide a lot of extra protection, especially against severe illness, hospitalization, and death. And so this is off the dashboard. You can see it at the bottom, but I wanted to just remind you, this is hospitalization. So Chicagoans who are hospitalized with COVID-19. And that red line at the top reflects the rate of hospitalizations that we've seen in unvaccinated Chicagoans. And so you can see, going back over the last year, how much more likely it's been that red line, that's who's getting hospitalized for the most part, folks who are unvaccinated. But then if you look in January, during especially the big Omicron surge, you see there's this light blue line and then below it the dark blue line. The light blue line are people who got their first vaccines but never got a booster, whereas the dark blue are people who are boosted. And so the biggest protection you get is getting that first vaccine. You get your risk goes from the red line down to the blue line at the population level. But then to go from the light blue line to the dark blue line, that's what the booster gets you. And so it really does have a lot of additional protection for hospitalization. And since the Omicron variant became dominant in Chicago, unvaccinated people more than twice as likely to be hospitalized with COVID compared to fully vaccinated people, but about 4 times as likely to be hospitalized compared to folks who are boosted. And if we look at deaths, it's even more stark. Red, again, Chicagoans dying of COVID who are unvaccinated. Light blue, Chicagoans dying of COVID who had their first vaccine but not a booster. And then the dark blue, you can see is almost flat there, is the Chicagoans who have died despite being boosted. And that tends to happen in people who are older, immunocompromised, et cetera. But here, you're about 3 times as likely, 2.6 times as likely to die if you're unvaccinated versus vaccinated. And then you're 6 to 7 times as likely compared to folks who are boosted. So that's the main reason to get the booster. They work. They're free, they're safe, they're available. We've not seen any safety concerns with them, and they do provide that extra protection. So as a reminder, when do you get the first boost? Unless you started getting vaccinated in the year 2022, if you're over 5, you should have had 3 vaccines already. You should have had that booster 5 months after finishing your initial Pfizer or Moderna, or 2 months after finishing your J&J. And you should get a second booster dose only if you are over 50 or you're moderately or severely immunocompromised, or actually if you started with J&J. So everybody should have had 3 vaccines, and if you're over 50 or immunocompromised, at this point, the recommendation is that you would have had 4 in total. And if we look at what's happening with boosters, we've seen 76% of Chicagoans over 12 complete their primary COVID vaccine series, but only 42% have actually had that booster. And I'm particularly concerned that people over 50 are really lagging in terms of boosters. Even if we just look at Chicagoans aged 65 and older, only 59% of that group have had even 1 booster. And that, folks who are older are the most likely to have the severe outcomes, and the boosters are the most important. So please, if you know anybody who's older or even just not sure, please talk about boosters because, my only goal is to keep people out of the hospital, keep them well, keep us open, all of these things, and they remain an important part of that. We were getting some questions about race ethnicity. This is on the dashboard also. You can see overall 77% of Chicagoans have had at least 1 dose of vaccine. If we break that down by race ethnicity, You see that Asian Chicagoans are the most likely to be vaccinated at about 85%. Black Chicagoans the least likely at 62%. And then both Latinx and white non-Latinx are in the 75 to 76% range. So there's still a lot of folks that are taking their chances with COVID. And I hope, at this point, we continue to choose to get vaccinated. And so obviously the big news this week was that COVID-19 vaccines for children under 5 are here. And I want to talk a little bit about that because that's been by far what we've gotten the most questions about. You can go to chicago.gov /under5vax if you want to learn more. We are doing a lot of provider education. We've been waiting for this for a long time. And so there's a statewide provider-focused program. We've been doing some webinars for your pediatricians. We've been working with the Illinois chapter of the American Academy of Pediatrics. So providers for young children here in Chicago are well educated on this and ready. We've also got some marketing, so you may see some of these materials, especially if you're at a doctor's office or around town with some of the data around that these vaccines are safe and effective and why we recommend it for little ones. We also have a campaign going with Chicago providers, trusted advisors. There's some videos. So if you want to hear from Chicagoans about their decisions to promote vaccines for the youngest ones, check out the website. And just to hit on a couple of the high levels, there are 2 vaccines that have been authorized for children under 5. The Pfizer vaccine, which is authorized for children from the ages of 6 months to 4 years, that's 3 shots. The dosage is just 1/10 of what the adult dose is. So we put here as a reminder the different age groups. The teenagers, 12 to 17-year-olds, their dose of Pfizer vaccine is the same as adults. 5 to 11-year-olds, the dose is 1/3 of what an adult would get. And then these little ones, it's just 1/10 of what an adult would get. And so there are the first 2 doses of Pfizer are given 3 weeks apart. And then in the studies, really a 3rd dose was needed, partly because I think that dosage is so low to get the level of protection in the blood that was needed. And so that's why you then get a 3rd, sort of like a booster. But it is all considered part of the initial series, at least 2 months later. And then the Moderna one is now authorized for kids of all ages. So from 6 months to 5 years, it's a 2-shot series. It's 2 doses, 4 weeks apart. 6 to 11-year-olds can also now get Moderna. Same thing, 2 doses, 4 weeks apart. And then 12 to 17-year-olds can, same thing, 2 doses, 4 weeks apart. You see, just like Pfizer, Moderna, the dosage for teenagers is the same as for adults. For 6 to 11-year-olds, it's half the dose. And then for the little ones, it's 1/4 of the dose. So let us know if you have more questions about that. Lots of places to get vaccinated here in Chicago for kids under 5. And importantly, their parents, grandparents, whomever, we'd love to get you up to date with a booster. So some clinics may offer Pfizer or Moderna or both. Your first stop should be your family healthcare provider, your pediatrician office. Give them a call. Many have this vaccine, and I'll show you that in a second. We are also, the city is standing up some family vaccination clinics on Saturdays at city colleges of Chicago. We have also added under 5 vaccine to Protect Chicago at Home, so you can get it there. Arturo Velasquez Institute with Olivio Medical Center is standing up. Some of the children's hospitals are. There's community events. We have our regular standing all the time CDPH immunization clinics, some regional vaccination clinics, some mobile vaccination events, Blue Cross and Blue Shield of Illinois, Blue Door, neighborhood center sites. And again, I would just check out the website, or you can always give us a call. We have had more than 200 providers, like pediatricians, family practice docs, et cetera, that have indicated that they will be vaccinating kids under 5. We got 31,000 of the the young child pediatric doses in the first launch, and we already sent out about 20,000 of those doses. So 46 providers got vaccines this last Monday, federally qualified health centers, hospital clinics, private providers, and most of them started vaccinating on Tuesday. And then the remaining doses in this first allocation will deliver next week. Pharmacies, Walgreens, and CVS received separate and direct allocation from the federal program. And you can see on the right here, there's about 126 sites at this point between providers and Walgreens and CVS and City Colleges and Blue Door. There's more details online if you want to see what's available when. Here is what I wanted to highlight. The city's family COVID vaccine clinics are coming back starting this Saturday. So we'll be at Kennedy King on the south side this Saturday from 9 to 2. We have both Pfizer and Moderna for the young children, 6 months to 4 years. And then we have Pfizer of all kinds for anybody older than that. First dose, second dose, booster dose. And then you can see we'll be returning 3 times to each of the sites to be able to make sure that we can finish the series. And so here's the details. And the free, we do recommend registering. Walk-ins will be accommodated as space allows. Again, chicago.gov/under5vax. And then I wanted to highlight Blue Cross Blue Shield's Blue Door neighborhood centers. These are newer, and we're excited because they're in some of the parts of the city that we've needed additional coverage. And so there's Pullman Center, Morgan Park, and South Lawndale, and the details are here. They will have both Pfizer and Moderna available. And as I said, we will also have anyone now age 6 months and older in the whole city of Chicago can get a COVID-19 vaccine at home for free. Through At Home, we are doing Pfizer, which is what we've done all along. We will continue to offer Pfizer through that program. We'd love to vaccinate not just little ones, but up to 10 other people at the same time. And we have appointments right now, Saturdays through Tuesdays, Saturday, Sunday, Monday, Tuesday, 8 a.m. to 6:30 p.m. Through the end of July, we still have $50 gift cards available for first and second doses for people over 5. And just as a reminder, if you catch COVID, regardless of your vaccination status, you need to stay home for 5 days. If your symptoms are resolving or gone by day 5, you can leave your house, but you got to continue to mask for really around everybody for days 6 through 10, because we do see people still, in most cases, they're feeling well and no longer spreading COVID by day 5, but we do see some of it in days 6 through 10. And if you have not ordered 3 rounds of free at-home COVID tests, please do that today. covidtest.gov. They won't ask for your insurance or any other information. They will come free of charge to your door. So if you don't have internet, people can call 1-800-232-0233. I've been using these free at-home COVID tests myself. They're from the federal government. They work very well. And finally, as always, if you have questions, give us a call, 312-746-4835, or chai.gov/COVIDvax. Thanks. Now we're going to get into your questions. All right. Rose Santiago from Facebook, starting off with a non-COVID question. What happened to the Art Institute Lions? Well, nothing to do with health, but I actually do know the answer. In early June, they were removed just temporarily for conservation treatment. They're doing some steam cleaning, they're doing some wax coating, and they are expected to return at the end of July. We've been really pleased. The Art Institute of Chicago, as some of you know, has these large masks that they put on, especially in the first part of COVID. Some of our Protect Chicago masks, and obviously they're such a symbol of Chicago. So we're glad they're getting cleaned, but nothing's wrong with them. And they will be back. And look, we can answer any question on this. Okay, DS Shin from Facebook. Any COVID symptoms you're seeing more than usual this summer? I wouldn't say that we're seeing any particular symptoms more than usual. It's more that we're seeing a lot of COVID that is often quite mild. We do continue. There's people, for some reason, people have been telling me they don't think you lose taste and smell with Omicron. You can lose taste and smell with Omicron. We've seen plenty of people have this temporary loss of taste and smell. That continues to be the most specific. Like if somebody has lost taste or smell, I'm like, that's COVID, right? Even until you got to get the test to prove it. But nothing else I would say that's particularly new or majorly different. Two more symptom-related questions. Danielle Perez on Facebook. Can someone with mild symptoms, such as a slightly runny nose and a mild cough, test negative, but still be contagious to others around their day 6? Okay, so let's talk about this a little bit. And actually, back to, DS Shin was saying anything different you're seeing with symptoms? Not really. But we are seeing more examples of people testing negative for some time and then having a positive test come up a little bit later. We think some of that is because especially if people are fully vaccinated and or if they've had COVID before, they're not getting as sick, they're like not mounting as much of an immune response, and it can take a little bit longer sometimes for that test to turn positive. The good news is, generally, if the at-home test is negative, you're not very likely to have enough virus to be spreading, to be contagious. So it's possible. Anytime you get a positive test, on an at-home test, on a PCR, positive is positive. You treat it as a positive, it's COVID. But if it's negative, and this is sort of to your question here, if you've got symptoms that might be consistent with COVID, and you have a negative test, but maybe you were exposed to somebody with COVID recently, or you're significantly concerned about it, I would say, first of all, obviously wear a mask. If you continue to test negative that whole time, it's probably not COVID, honestly. If you wanted to go get a PCR test, it is a little more sensitive, meaning it's a little more likely to turn positive faster than the at-home ones are. But honestly, I just use the at-home ones. So I would say if somebody had mild symptoms, I'm not sure if you're saying like there was a positive test and then they were negative. Maybe that's what you mean. If somebody had a positive test, they had mild symptoms, and you did a home test and it was negative by day 6, they're probably not contagious, but you should still wear that mask in days 6 through 10. So nothing changes based on testing results, with the recommendation of staying home for the first 5 days after your symptoms start, or if you don't have symptoms, after your positive test, and then days 6 through 10 wearing that mask. That's regardless of what happens in your testing. Comment here from Alexandria Deanne on Facebook. She says, it feels like a lot more people I know, including myself, I am vaccine boosted, are having some more intense symptoms or lingering symptoms with the latest variant. Is that a trend you're noticing as well? I don't think these are good questions. I would say we've not seen that very clearly. I can tell you that there are some good, more long-term surveys and studies that are going on to really understand the different ways in which COVID is showing up. We've seen less serious outcomes, certainly less long COVID, thankfully, although we do still see some with Omicron. But yeah, I wouldn't say we have data that really is suggesting that. But with BA4 and BA5 in particular, there were some animal studies that showed, for example, a little more what we call pathogenic, a little more problematic, like in some of the animal lungs and stuff where tests were done, mice and et cetera. And potentially BA4, BA5 could be a little more intense. But overall, I think, if you're vaccine boosted, I just say thank goodness you're vaccine boosted if you were having, significant symptoms, because that's a sign that you could have gotten even sicker. Laura Dembrowski on Facebook, are there increasing concerns over variant BA4-5? So I would say there are not increasing concerns. I'm concerned about BA4-5. My biggest concern is that just like some of the other variants that have come before, it doesn't look like prior infection is as protective. And so, unfortunately, we are seeing some people who had Omicron now, like in January or February, potentially get reinfected with this subvariant of Omicron. And that's a little different because previously, if someone had Delta, you weren't going to see them sort of get a subvariant of Delta again now. But I would not say I have increasing concerns. The numbers are going up for sure. It's infectious for sure, but it doesn't seem to be putting more people in the hospital, at least here in the Midwest or in the U.S. at this point. I'd say it's certainly what the world is watching right now. There was a little bit of an increase in hospitalizations in South Africa, which we've been watching. But overall, I would say it's it's just, for me, it's just not a good sign for how quickly the virus continues to mutate, because as we develop an updated vaccine, I do think there will be a vaccine most likely in the fall, in probably October, November, where it's an updated vaccine to be more protective, not just against the original version of COVID, but the ways in which it's changed first. So Omicron, for example. But the problem is, as Omicron itself keeps mutating so quickly, it takes a number of months, of course, to make sure you've done the appropriate studies, you've manufactured the vaccine, you've distributed the vaccine. And so the scientists have been struggling a little bit with, when do you sort of call it and say, we have to stop, we have to move now. And BA4, BA5 came so quickly that there's worries that, if you made the vaccine for the fall right now, you perhaps wouldn't have as much protection against BA4-5 as you would against Omicron. So this is, so I'm more concerned in like a long-term way that it continues to mutate, but nothing at this point that's making me alarmed. And in fact, the fact that we're seeing increases in BA4-5 so quickly here without major increases at this point in hospitalizations, to me, is quite reassuring. And Jenna Martin, okay, and that brought a number of questions. I see Jenna Martin, Benjamin Vigilant, etc. on Facebook asking about reinfections. Jenna Martin says, my fully vaxxed family all just had COVID. Very mild for all, 5-year-old with no symptoms. Since there's no way to know what variant you had, what's the outlook for reinfections? Are we all back to square one? We're definitely not back to square one. Number one, because you're vaccinated, that's the most important thing, right? That's the reason, if I was going to choose one main reason why you all had mild outcomes, the 5-year-old had almost nothing. We're seeing a lot of that right now. There's no way to know for sure what variant you had, but it was Omicron for sure. I can tell you that, because everything we're seeing right now is Omicron. And statistically, you may have been BA4-5, you may have been BA2.12. What I would say is, we've been using all along that for about the first 3 months or so after somebody gets a COVID infection, we've generally seen some additional protection from that. People not very likely to get reinfected in those first 3 months or so. I think there are still a few questions with that BA4-5, given that we are seeing some people get reinfected, but for the most part, the more recently you've had COVID, especially if it's on top of full vaccination, you probably have relatively good protection. So you're definitely not back to square one. And the more recently you've had it, I would say, you've been exposed to the most up-to-date, sort of the most infectious variant that we've had. So I think I wouldn't have major concern at this point. At all, especially if you're all up to date with vaccines. Jeffrey Taylor on Facebook, this is a good question. I'm over 50, fully vaccinated, and have had 1 booster. So over 50, fully vaccinated, and 1 booster. He says, I'm eligible for a second booster. Right, but I hear that Moderna will have a vaccine in the fall that is Omicron specific. Should I get a second booster now or wait for September when the new one will be available? I would get a booster now. Absolutely, 100% get a booster now. You getting a booster now does not in any way stop you from getting the booster in the fall. We've seen no evidence that repeated boosters in any way are damaging to the immune system or make it less effective. The reason to get that second booster now, and the reason it's actually recommended, especially for people over 50, is that it helps give at least some additional protection while we're sort of getting through this surge that we've been getting through, and it's a real surge. And knowing that people over 50 are more likely to be, to get severely ill, that's who we especially want to help keep out of the hospital. So I would 100%, if you're over 50, I would recommend getting a second booster now, and then probably for everybody, I'm guessing, at least for adults, we will have an updated vaccine in the fall. It may be October, it may be November. Again, it depends a little bit when we sort of call it and say we gotta move ahead. We gotta make these vaccines now. We can't wait to see what the virus continues to do in the meantime. That's what we do for flu every year, right? Every year, the reason there's a flu vaccine every year is that each year the scientists look at the variants, the strains of flu that are circulating in the world, for the most part, like they'll look in the southern hemisphere, which they're in summer when we're in winter and vice versa, and they'll make a version of the vaccine that is specific to those strains of flu. So it's kind of like that. They're making a version of the vaccine that is more specific to Alpha and Delta and Omicron. It'll still just be one shot. And it's not, this is just me speculating. I don't know for sure that this will happen, but I expect that probably there will be one that is sort of updated in the fall. But in the meantime, I would recommend coming up to date with existing boosters. All right, some under 5 questions. Marie says, if my 3-year-old gets the smaller dose vaccine right now, will they have to get the larger dose when they turn 5? That is a beautiful question. So the way that the dosages have been calculated, it's based on sort of body weight and size, et cetera. Your child should get the dose of vaccine for the age that they are. So if your child is 3 right now, they will get all of their COVID vaccines right now, of course, while they're still 3 or 4. If we're still doing COVID vaccines when your child is 5, they would then start to get the dosage that's sort of 4 or 5. But otherwise, this is similar to somebody's got a question of, do I wait? My child's about to turn 5, should I wait? I would just get the first dose for the children that are younger, and it's the same product, it's the same vaccine. It's just the dosage, and it's based on body weight. So I hope that that's helpful. All right, Lisa Marie Walsh from Facebook. Is Pfizer the recommended vaccine? Which is more effective in your opinion for children 5 and under? So I have a 4-year-old nephew, and my sister, of course, asked me this exact same question. And I told her the same thing that I am telling you, which is, first of all, talk to your doctor, see what they have available. I want you to get whatever your provider has first and foremost. Those little ones, we especially want you to get them at your pediatricians. It's a way to make sure you're up to date with everything. They can check on it, et cetera. So whatever your pediatrician has, if you have a pediatrician, that is the one that I 100% recommend. Now, my sister happens to be traveling out of state, and so she can't get it through her pediatrician with her son. And so in that case, she was like, should I get Pfizer or Moderna? And I said, get whichever one you can get. So I don't think there's a major difference. The safety data looked good on both. The efficacy data looks good on both. I'd say some people choose Moderna because it's 2 doses rather than 3. But honestly, I think we may end up with a 3rd dose down the line, potentially more like a booster for Moderna anyway. I don't know that for sure. But I think regardless, I don't think there's a big difference. And I told my sister I had no preference as to which one my nephew got, but that she should go ahead and get him one and not wait until she was back in Michigan where she lives. Lisa Beamer on Facebook. Is there an uptick in Norovirus in kids 6 and up right now? Are you thinking this is linked to the coronavirus? So we haven't seen a big problem with Norovirus. If people don't know what Norovirus is, it's the one that tends to very quickly spread through cruise ships or sometimes schools. It's a GI. It's not, nausea, vomiting, etc. It's not linked to coronavirus. So except that perhaps if people are getting more lax in terms of washing their hands, we're seeing a little more spread. But no, we've not been seeing big problems with Norovirus. And Norovirus tends to really be like everybody gets, eats a contaminated food, for example, or there's some spread in an event. And so it tends to be a lot of people get sick at once and then they're better a couple of days later. It's not like it's not like spread typically and continues on the way that COVID has. So that one I'm not too worried about. So Faye State on Facebook. Is there any relationship between smallpox and monkeypox? Does the smallpox vaccine have any effect on monkeypox? Good question. So smallpox and monkeypox are in the same family of viruses called orthopox. Orthopox is the family. Smallpox is one of the few diseases that we have successfully eradicated from the world. So there is no smallpox, or there should be no smallpox in the world. One of the reasons there's been a lot of attention to monkeypox is anything that sort of is behaving a little bit unusually in the orthopox family, we want to pay a lot of attention to, because smallpox itself used to be a very deadly and dangerous disease. However, they are very different, and although they're in the same family, they're not the same disease. The smallpox vaccine can have some protection actually against monkeypox because they're in the same family. There's a couple of different vaccines that are available. At this point, there is not a recommendation for vaccination in advance around this, but we're continuing to monitor, and if there are people who are at higher risk, et cetera, there may be some opportunity for what's called post-exposure prophylaxis, meaning if they've been exposed, we can give some treatment that helps decrease the risk of monkeypox. But for the general population, we do not have a vaccination recommendation at this point for monkeypox, and I don't anticipate one. Okay. Let's see, what else do we have? Francie Swidler from Facebook. What kind of data do you have on Paxlovid rebounds? Were those who initially tested negative while taking the drug and then didn't continue isolating and tested positive later? Could that have an effect on case numbers? So I would say we don't have excellent data on this. This is something that was seen in the initial studies a little bit when Paxlovid was approved, but in like 1% to 2% of people. Anecdotally, we've been hearing that this is happening a little bit more. Let me just explain what this is for people who don't know. So remember that if you get COVID, if you get diagnosed with COVID, whether or not you're vaccinated, if you are at severe risk, high risk of a severe outcome, if you're older, if you have underlying conditions, I want you to call your doctor because we are really wanting to make sure that you can get the early treatments that are available that significantly cut your risk of being hospitalized or dying. So Paxlovid is the most available and effective of those treatments. It's a pill. You take it for a few days, but you need to take it pretty soon after you get infected. What we've seen is that in some cases, people who are at higher risk take Paxlovid right at the beginning. You know, they test positive, they take Paxlovid, and then you know, they feel better, things are going well, and then they potentially are testing positive again, often in that sort of 6 to 10 day window, or even sometimes a little bit after that. There's been no change in terms of recommendations here. We definitely still recommend that people get Paxlovid. We don't consider that a new infection. It's more that most likely, you know, the Paxlovid is working to kind of stop the virus from copying in your body, it's decreasing it, and then potentially as you finish that course, you could see a little bit more of a rebound. We're not sure, honestly. There are studies going on about, is this some pockets of virus that were not eradicated? Is it just the levels were lower? Plenty of people take their Paxlovid and never have any additional issues. But if we do see people have a little bit of this rebound a few days, we recommend not, at this point, not repeating the Paxlovid, not doing anything different, but just making sure you're watching that whole 10-day period and then staying in touch with your doctor. So that's what I would say. I don't think it's having a big effect on case numbers, though, particularly because we're doing Paxlovid even in the absence of needing the formal PCR testing. Lisa Balde-Venaria on Facebook says, are our numbers actually going down, or is it because more people are testing at home? I know people with COVID who aren't reporting at-home positive tests. So I would say that our numbers are, this is why we use hospitalization data a lot, because that is less affected by what's happening in terms of testing. We know there are a lot of people not reporting at-home tests, especially, like nobody almost reports at-home negative tests, and very few people report the at-home positive tests. I care a whole lot more about you acting on the results of a positive test, getting that test result early, isolating, quarantining, you know, letting your contacts know, getting Paxlovid early. All of that is much more important than us being able to count every single case. We have a lot of different ways that we monitor what's happening with COVID. And the reason that I'm confident, you know, that we've moved from high to medium, we follow things like COVID in the wastewater. We follow things like people going to emergency departments and subsequently testing positive for COVID, which is less dependent on how people themselves are testing. We look at, like I was showing you, we know that as testing changes and positivity changes, we keep an eye on all of this. But overall, we continue to be in a reasonably good place. I'll be even happier when we can get back down to low in terms of our community COVID risk level. But COVID's not gone, and it's not going to be gone. Certainly in the short term, and hopefully it will continue to evolve, and hopefully it will less and less be something that puts people in the hospital or threatens our society. Jim Pash on Facebook says, what will it take to lift mandates on police, lifeguards, et cetera? I'm not sure if you need vaccine mandates or what, but the vaccine requirements remain in place. We had a vaccine requirement for a short period during the Omicron surge. That was for the high-risk settings because we were seeing our hospitals get overwhelmed with COVID patients, and especially unvaccinated COVID patients. So to protect the hospitals at the time significant surge, we did a short-term vaccination requirement for high-risk settings. That we would potentially turn to again if we saw a major surge, if we saw our hospitals getting threatened. But the requirements around first responders, for example, being vaccinated have not changed. I don't expect them to change. You being vaccinated, especially in settings that are less controlled, EMS is regularly interacting with people with a lot of underlying conditions, often conditions where you can't be keeping 6 feet distance, masks might come on and off, et cetera. And so vaccination does remain a requirement, and I don't expect that to change. Vina Clavelam is wondering, will there be testing at CPS summer schools? So CPS is working on a number of things here. There will certainly be testing I know they're planning to continue some of this test to stay, so that if there is a positive test in a classroom, as opposed to needing to quarantine large numbers of people, you can instead actually do some testing to help kids stay in school. So there will certainly be some of that, and we can talk in the future in a little more detail. CPS is also planning to be doing some additional vaccination this summer, even including for kids under 5, focused on the early childhood education pieces. So I know that that's going on. All right, I think we are just about at time. I've got an email here that came in from Tanya Mashinsky, which they've sent over. Tanya says, thank you for the Facebook show. She says, I have a question. I see a doctor who, if I report a side effect, says, but that's not a known side effect. The residents he teaches say the same thing. They dismiss the side effect, implying that it is not known. That if it is not known, I could not have had it, or it's not possible, or I've imagined it. But isn't it true that if I had the side effect, I had it, and it is therefore possible? That's a good question, Tanya. So here's how doctors tend to think about side effects. First of all, you are absolutely right that everybody is different, and that there are people who may have side effects that are unexpected or very rare. But whenever a drug, a vaccine is authorized, there's these very big trials, right? And so if you actually, if you, I don't know if you're talking about a medication or a vaccine, but in any case, if you look at the package insert, or you download the additional information from the internet, or you ask your pharmacist, you will see a lot of detail in there about side effects. Those side effects are what we're seeing in the trials. And in the trials, remember, we do a comparison between people who get the real medication or vaccine and a placebo, a dummy vaccination or medication or vaccine. And you follow both of these groups forward. The patients don't know if they got the real medicine or the fake medicine. The doctors don't know, did they get the real medicine or the fake medicine? It's all matched behind the scenes. And then at the end of the trial, they unblind it, meaning they look and see who got the real medicine or vaccine, who got the dummy. And then they compare what happened between these two groups. So anything that happened as far as potential side effects in these two groups gets collected. And so if you find, for example, that 20% of the people in the group that got the medicine had a headache, but 20% of the people in the group that got the fake medicine also had a headache, you'd be like, I don't think that that's a side effect that's likely associated with this vaccine or this medication, because the people who got the medication were not more likely to have a headache. Whereas if 20% of the people who got the medication reported a headache and 5% of the people who got the placebo reported a headache, you'd say, okay, there's a good chance that headache is a more common side effect. And so doctors, we learn sort of what are the common side effects with each of these, and there always can be rare side effects. Usually if your doctor is telling you that they don't think it's related to a vaccine or to a medication, it has to do with it not having been a side effect that was seen in these big level trials, or that the timing of it doesn't seem like it's consistent. But it's not impossible, you're right. I always, it's kind of like science, right? Like science is all about the evidence and the highest likelihood based on the evidence that is known. So I hope that that's helpful to you. All right. I think we are just about at time. So I will go ahead and wrap up here. Oh, I've got one more good. Susan Villanosa on Facebook here had asked what constituted a COVID outbreak. And I wanted to, she asked that last week, but I wanted to just mention that quickly because an outbreak, the general outbreak term just means more cases than would be expected. So I told you we don't have smallpox in this country, or in the world, even like one case of smallpox would be an outbreak, would be a big deal. Whereas something that is very common, you sort of know how many cases of X you would expect. And then an outbreak is if you're seeing a major increase above that for any disease, sexually transmitted infections, et cetera. But for COVID specifically, we define outbreaks as when there has been an outbreak of COVID where there has been transmission of COVID, likely transmission of COVID in a given setting. And we define that with different numbers in different settings. So for example, if there are more than 5 cases of COVID that are all linked to a single workplace, a single site, within the appropriate period of time, 5 or more would generally be considered an outbreak. In a school setting, K through 12, the state actually defines it as 3 or more that have likely linkage in the school setting, whether that's a classroom, whether that's a field trip, as opposed to, you wouldn't call it an outbreak if there were 3 students who, all lived together who had, who all had COVID. It's about assuming that there's a potential spread in school. And then actually in early childhood and some of the higher risk nursing home settings, et cetera, even 2 cases is actually considered an outbreak in terms of making sure that we're working to get all the right precautions in place in the follow-up in settings where vaccine previously was not available or the most vulnerable. So there actually are some slightly different cutoffs in terms of those numbers. But basically it means we're concerned that there has been spread of COVID beyond what would be expected. And and as a health department, we want to figure out what happened there. Were people following protocols? Are there problems with the ventilation? Is there something unusual? A major outbreak could be a sign of a new variant even, actually. And so we'll do additional genomic testing and some additional follow-up. And especially if there are new variants, that's when we're paying a lot of extra attention. So I hope that helps. All right, I do have one more. We'll take this one. Christina Basile-Brees on Facebook says, what about second boosters for under 50? A lot of us were boosted back in the fall. Even those with high-risk medical issues can't get boosted unless immunocompromised. Seems like an issue for waning protection against severe disease. Yeah. So the reason why... and again, talk to your doctor because I don't know exactly what your high-risk medical issue is. There are some specific guidelines. You can see them on the website around who would be considered qualified. And it technically is moderately or severely immunocompromised for people under 50. But the main reason is that it gets you some additional protection, but probably not an enormous, large or long-term kind of boost. It's important for people who are at high risk for severe outcomes. But I'll tell you, I'm not over 50. I don't have any serious underlying conditions. I have not had a second booster. My third dose of COVID vaccine was last fall. I still have not had COVID either, to the best of my knowledge. I expect that I will be taking taking a sort of booster, if you will, this fall. But I expect that that will probably be the updated version that has been made more specific to the ways in which the virus has continued to change. And so, you know, it's sort of wanting to make sure that we're using resources appropriately. There's still a lot of people around the world who haven't had the opportunity to be vaccinated, but mainly it's that the people who really need that extra protection to sort of get us through to fall are the people with the higher risk for severe outcomes. So I hope that helps. Talk to your doctor, certainly, if you have concerns. We will be back on Tuesday at our regular time, 11 a.m. Good questions today, as always. I am excited to be seeing some of these young children getting their vaccine. I know parents of young kids have been waiting a long time, and it's nice that now we are able to offer some protection and some peace of mind, really, for everybody in Chicago. So that's some good news. We will be back on Tuesday. We may do a little more on monkeypox on Tuesday if we continue to get a lot of questions about it. In the meantime, please be well, and thanks for tuning in. Bye-bye.